That's great. Thank you so much, Dr. Sandra, Dr.
Thank
Trump.
you.
And yeah, just a comment regarding to both of your presentation. There are lots of variables in the PRP, and based on how we prepare the PRP, how we process the PRP, we can change the properties. We can enhance some properties or decline some others. For example, it was an idea and a kind of topic among the Society of Sexual Wellness experts regarding to preparation of the PRP using different anticoagulant. So we know one of the reason of using the PRP for this specific practice, this specific field, is increasing the blood flow by vasculogenesis and angiogenesis. One of the key factor can influence a lot in this specific target, is this specific aim, as the anticoagulant. So in MSITE, we use the sodium citrate as anticoagulant, but other systems that are using ACDA. One of the big difference between the ACDA and the sodium citrate is the influence on the angiogenesis and vasculogenesis. Based on several studies, they showed the ACDA can hinder the VEGF function and endothelial cells migration and proliferation, which is essential for sprouting, for angiogenesis and vasculogenesis. You know, even simple things like anticoagulant, which is work, both of them, ACDA and citrate, both are very common for preparation of the PRP, but based on the purpose, we are going to have angiogenesis and vasculogenesis. Changing the anticoagulant can increase or decrease the outcome and efficacy of the PRP for that specific aim. Okay, is there any question? Please.
Can you stop sharing so that way we can, our face will be on the screen when Chris. Yeah, there's a button that says stop sharing. Right now you're muted.
Sorry, I'm trying to figure out how to stop the sharing.
It's a red button. There's like a red button that
okay.
You'll see in the red button. Sometimes it's on the upper left, sometimes it's on the upper right. So it'll say, go to Zoom, it'll say button and stop sharing.
Okay, got it. Recording my screen. I'm gonna just.
There we go. We got it.
Oh, sorry about that.
Okay.
That's great. Okay, so if there is any question, please send the question through the chat. I'm able to see the question, and I will read the question for our panelists. So yeah, it seems there is no question. Oh,
I see something pop
okay.
up.
So yeah, Dr. Beata Teralik, she maybe not a question, but just a comment that at our clinic for ovarian rejuvenation, we also active PRP mechanically. That's good. That's good to know. Yeah, Dr. Beata Teralik, as one of our doctor, she is OBGYN specialist, and we ran the webinar with her in our last session in the reproductive medicine. So I think there is another question.
That's very interesting about ovarian rejuvenation. But what I noticed was that Dr. Sandra doesn't activate with calcium chloride. I do activate with calcium chloride. I mean, I also treat a lot of ED as well. And I use 240 cc's of whole blood when I do an ED treatment, and we would inject in 20 cc's of PRP volume as well. But I would treat the guys that have prostatectomy, and I would treat the severe cases as well. But I activate my PRP, both female and male. But what's interesting is that he gets result, I get result, and I think it's what I see what your comfort level or what you've been trained. But what has been kind of the debate about activation and no activation with PRP, Sina?
So, okay, so I'm the fan of non-activation, but regarding to the based on the experience for specifically for sexual organ, activation could minimize the pain and soreness, but you need to immediately inject. There are a couple of different scenarios. When we active the platelet, we actually start the degranulation of the platelets, and we start the platelet to start to release the growth factors, cytokines, and blah, blah, blah. One of the growth factors which can be immediately released upon the activation is the TGF-beta. The half-life of the TGF-beta is very short, it's minutes. And when we activate the PRP, and if we inject later and it takes time, so maybe we lose some of the functional TGF-beta. In some case, maybe we don't need TGF-beta, for example, if we want to treat the scar, so for a scar, TGF-beta is harmful because it increases the collagen synthesis, and we don't need collagen synthesis. In that case, we prefer to minimize the collagen synthesis, specifically for hypertrophic scar. But in some case, maybe we need TGF-beta. That's why it's better don't activate and lets the body, based on the presence of the collagen, which is one of the most strong agonists for the platelet, lets platelet get activated because of the collagen within the tissue. But these simple difference, activation and non-activation, could change sometimes based on the target. If we want TGF-beta or we don't want TGF-beta. Another growth factor with short half-life is the VEGF, which is essential for angiogenesis. The VEGF half-life is around 20 minutes. So if we activate and then inject 30 minutes later, maybe we lose half amount of the VEGF, functional VEGF. When you go through the literature, specifically in vitro studies, they show, we have VEGF, TGF-beta, or other cytokines consistently released for a couple of days. Yes, which is true. With ELISA, you could measure them, but I would say they are not bioactive. They are not functional. You have the TGF-beta, you have the VEGF, but it's not functional anymore. And another thing I wanted to get your idea about that, since we know for stress urinary incontinence, platelet works very well now, specifically if you inject through the pelvic floor muscle, specifically in women. There is an idea I saw recently in Egypt, I think, in Kuwait, and I think in Thailand. I know just these three. They started injection intrapelvic floor muscle for PE, because the idea probably comes from Kegel exercise, which helps for premature ejaculation. And if we could, with the biologic, strengthen the muscle on that area, maybe we could at some point help for premature ejaculation. Have you had any experience regarding to that, or do you have any comments for that? I guess it should be very painful injection, but I don't. Yeah,
I don't inject in that area personally. It's just like you said, it's a very sensitive area. One thing I do encourage men to do, besides, we notice that when we put them on hormone therapy as well, and testosterone, they tend to get better. Their PE is reduced with hormone therapy. I've noticed that. Secondly, when they exercise more, right? And I said exercise below the waist, squats, anything that's using the lower body exercise, you're strengthening the Kegel muscles there as well, right? And the pelvic floor. So that's one thing I encourage men to do always when it comes to PE or ED is just you got to start moving your lower body and start increasing blood flow there and developing muscles there and strengthening everything down there as well.
I actually do inject the pelvic floor by ultrasound guidance because I also do MSK. So I use ultrasound guidance. I will use a curvilinear probe and will actually inject there. If I feel that the pelvic muscle is very lax or weak, and especially I would do that in men with prostatectomy. I would do that in men with metabolic disease, such as having comorbidities of diabetes and obesity and high cholesterol. Yeah, and we would do that. We also inject into the prostate, which is a very easy injection under ultrasound guidance, out of plane, of course, but the prostate is literally just about 1 centimeter just below the perineal area. Very easy injections. We have seen great result with PRP, and I think you mentioned that for benign prostatic hyperplasia. In reducing nighttime urinary symptoms. So, I don't do it in everybody. I do it for some, I do it a lot for women with dyspareunia. So oftentimes dyspareunia is really due to a more spastic muscle in the pelvic muscle area rather than laxity. In men, is more due to weakness and laxity, but in women is really more due to more spastic muscles. So different approaches for a different indication. That's what clinical medicine is all about, right? It's not just a cookie cutter formula. You customize it to the needs. And I wanted to address Dr. Paul's question is that I don't use laser, but I use
Sorry,
focus.
would you please read the?
Oh yeah, right.
because-
The question is, I forgot that not everybody have access to. So Dr. Rowan Paul asks, is anyone augmenting with class 4 laser? And what are the most common peptides that are used? And so I don't use class 4 laser. I use the focus shockwave. So before I inject PRP, and either for male or female, we will prime the area with the focus shockwave. And first, we use the store. And for female, we would do the clitoris area. We would go into the whole labia majora, the whole vulva area. And then we also will also target the anterior vaginal wall. And we would do that around 0.15 intensity, and a total, I believe, 5,000 shots. For men, we use 7,000 shots, and for men, we target the penis, the base of the penis, the prostate, the pelvic muscle, as well as the neurovascular structures in just above the ischial tuberosity. That's about 7,000 shots. For ask the question about peptides, I sometimes will use PT 141, but I have more patients getting side effects from that, as is nausea and vomiting, more than even beneficial. So I'm using less and less of that. Sometimes I will use BPC 157 to accelerate the healing a little bit more in patients that I know that are metabolically not at optimal state for healing. I would do that in some patients, particularly diabetics, or in patients that has had cancer treatment before, particularly in prostatectomy. Now, I do see a lot of severe cases in ED cases where they had prostatectomy and or they had like nerve damage or even Peyronie's disease as well. So some peptide, but a lot of time it's really more regenerative using PRP and shockwave, and now Botox. Now, Chris, do you use Botox for ED?
I haven't. I probably need to learn that from you, Dr. Trong. That's awesome.
That's my go-to. That's my go-to.
Really?
I've been doing this in 2023. Yeah.
One question regarding to the peptide I wanted to ask. So if you want to compare the peptide with PRP, which one is longer lasting?
Well, I don't think you can look at it like peptides are kind of temporary. The PT141 is temporary. I usually
So
call it
sorry,
the weak.
Botox, where it says
Okay, sorry,
PRP,
Dr. Trump.
which one is long lasting compared to another one?
Right. So Botox, according to the study, there was a study that came out in June of 2023 out of Israel, and another one that came out of Korea. So what they found is that this is for ED that has failed PDE5 inhibitors like Viagra, Cialis. What they find is just injecting Botox alone has actually reversed their ED, and they're able to have erectile function again. If they use 50 unit of botulinum toxin A, which is Botox, they will see improvement in their ED at 6 months. But if they use 100 unit, they see improvement in their ED at 9 months. And so that's just Botox alone without PRP. So after I read that study, I said, well, I'm just going to add Botox. And how Botox works is that of course, it relaxes the muscle, it relaxes the corpus cavernosum. And so when the corpus cavernosum is relaxed, that's how actually Viagra and Cialis work, right? Because it releases nitric oxide, it increases cyclic GMP, and that's how the smooth muscle is relaxed. So it acts like a continuous Viagra on the penis, the muscle. So the muscle is continuously relaxed. So it's easier for a man to get an erection. And especially if a man has some type of performance anxiety, or if he even ED. So it's already set the stage for relaxation of the corpus cavernosum. So it makes sense, but emerging studies are coming out also saying that the Botox is also helping with neurogenic activation as well, to the neurogenic regeneration. So for me, it just makes sense to combine that with the PRP. So, our protocol for ED is that we do 240 cc's of PRP with 20 cc's of PRP injection into the corpus cavernosum, and then 100 units of Botox and focus shockwave, all done at the same time with different syringes, of course. We don't mix the Botox with the PRP, but do different syringes. I don't do as many injections as Dr. Asandra. I actually do 2 on each side of the shaft, a total of 4. And I agree with you, I don't do the glands as well. But I do activate, and I inject with a 27 gauge half-inch needle. But I put in 20 cc's of PRP. We would do the PRP first, then we would do the Botox second, but the shockwave is done
Always
first
Always,
before
yeah.
all that.
I would say I'm starting to see, people aren't just coming in for PRP. They're not saying, I just want PRP. It's usually they want other types of treatment. They're going to want the shockwave, and I usually incorporate the two together. So it's not just, I hardly have any guys coming in now just saying, I just want PRP. And I always tell them you're going to have a better shot if you do, shockwave and other types of modalities with the PRP, not just PRP alone, obviously.
Yeah, it's still regarding to the Botox for blood flow, that makes sense for me. It increased the blood flow immediately, and it could be even faster response than PRP. But PRP could be more long-lasting, which is more regenerative than Botox.
Oh, definitely. No, definitely. I've been doing PRP to the penis in 2012, and I definitely see a longer benefit of PRP before I even start doing Botox. I just like to get these guys and a faster result. And what's interesting, if you combine the Botox and shockwave and the PRP together, they actually get result in about 5 days. Most of these men are starting to see morning erection and firmer erection within 5 days. So I just want them to get a bang. So patient comes to see you because they have ED. They just want to get erection again. They're not going to tell you what treatment modality to use. Use that the clinician will offer them what you feel is most appropriate for them. So we bundle it together. We don't let the patient choose. We just, well, this is the ED package. This is what you. But that's my protocol. So my protocol is more of more aggressive and quick result at this time. Okay. I think that we have another question, right?
Yes, there is a question from Dr. Turalik again. Question for Dr. Tron. Do you use it for patient with endometriosis?
Oh, PRP? No, I don't. But I think the reason why is because I like to stay in my lane. If I'm a gynecologist, I will certainly consider doing that. Because you would have to inject it in the endometrium, and I just don't feel it is in my scope of practice, of my specialty to do that. But I certainly feel that it definitely can help. I don't think it'll hurt. Come on, it's your
Yeah,
own
she's
anti-inflammatory.
OB/GYN, and so that's why she asked that question.
Yeah, no, I definitely think if you have the skills, that's your specialty. Definitely consider that. I believe there was a study that did use PRP as for endometriosis. I don't know. I don't see why it wouldn't help at all.
And one question for Dr. Asandra. You mentioned you use the PT141. So it works for both men and women in a same level, or for men it's a little or not little less effective.
Well, I think when I use PT141, it's going to be different for men and women in terms of like for women, it's more of a libido stimulator, I think. But like Dr. Trump was saying, there's a lot of side effects like nausea, flushing,
Yeah,
stomach ache. So what I tell them to do is really start at a tiny, tiny, tiny dose first, and then kind of work your way up. It's supposed to be 1 milligram. I tell them start at like 0.25 milligrams and see how they feel with that. And they do say it's definitely libido arousing. We kind of call it the weekend shot because it lasts about a weekend. But for men, a little bit on the libido side, but mainly what it does is somehow, and I don't think they know the mechanism of action yet, but it induces erections. Like you're just getting erections all day long. It's kind of a cool thing. But again, it is dose dependent sometimes, and there is that side effect with it as well that turns a lot of people off. They said they can't handle it.
The interesting things about most of these types of the treatment and medications, these effect and effectiveness comes as the side effect. When they were in a trial for something else, they found that the side effect is going to be helpful, specifically for Viagra or Sildenafil. They found that the side effect is very good, and that side effect helped Pfizer from bankruptcy to go jackpot for the sky. And I think for PT141 it was the same. And the side effect was increasing the libido for ladies. And I think they started with a kind of a spray, nasal spray, and then they found that injection is more favorable. And that's great. Yeah.
Yeah.
Interesting. Well, one thing to consider PT141 is also a melanocortin. So it's one of the side effects, darkened skin. So some patient will notice they have darkened skin as well. So I used to use it a lot until I tried it myself, and I had the nausea, and I had the nausea and the flushing. It was not very pleasant. But however, my husband used it, and he doesn't have any side effect even on the maximal dose. So it's very dependent on the user. The last time I used it on a patient, I used it on a 78-year-old man who had prostatectomy and wanted to try it. He actually wanted to try it. I give him like the little tiniest dose you can give, like 0.1 cc, and he still had nausea and vomiting. He was vomiting so much he became dehydrated, had to be hospitalized, had IV hydration. And so you just never know who is going to react to it well, who's not. But in my experience, a little bit different. I have more patients with more side effects than in benefit. So I use it very, very little, and I hardly prescribe any for women because once we balance their hormones, the women do pretty well as well too. So how about you, Chris? Do you use PT141 quite a bit or not as much?
I for the same reasons you did. It's gonna we get a lot. We have some women that love it, and they'll just say, "Oh, you know what? I'll suck it up because this weekend I'm gonna have a fun time. I'll just use it for the weekend." But they do get the nausea, vomiting. That's why I tell them you gotta start low on that stuff. very low doses.
Alrighty, that's great. It was very, very informative for me, and I bet for all of our audience. And thank you so much, Dr. Sandra.
Thank you, guys.
Dr. Trong, for joining me. And yeah, you all have a wonderful weekend and also wonderful evening for West Coast, wonderful night for East Coast. So we'll see you in our next webinar almost around 4 weeks. Thank you.
Thank
everyone.
you. Bye-bye.
Thank you, guys.
Thank you for joining us in this session of EMsight's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.